Madam Chair and members, for the record, my name is Jessica Newland. I'm the Assistant Research Analyst for the Health and Human Services Committee. Senate Bill 1377 establishes dental therapists as individuals who are licensed and engaged in the general practice of dental therapy in all related and associated duties. The bill establishes guidelines for the Board of Dental Examiners when issuing or renewing a license for a dental therapist. The bill outlines educational requirements for dental therapists and lists the duties they can perform subject to a written collaborative practice agreement between the dental therapist and a practicing dentist. Collaborative practice agreements must address various limits and protocols for the dental therapist. Dental therapists are prohibited from entering into a collaborative practice agreement until they have completed 400 hours of dental therapy clinical practice under the direct supervision of a dentist. The bill stipulates that the supervising dentist's presence, examination, or diagnosis is not required for the dental therapist to practice authorized procedures unless specified by the written collaborative practice agreement. Madam Chair, there are two amendments that I would be happy to explain.
Please explain.
The 5-page amendment in the Chair's name, dated February 14th, 2018 at 2:43 p.m., requires an individual to be a licensed dental hygienist before becoming a dental therapist. The amendment also increases the number of required clinical practice hours from 400 to 1,000. Additionally, the amendment requires the supervising dentist to be within 10 miles of the practice setting in which the dental therapist is practicing. The 11-line amendment in the Chair's name, dated February 14th, 2018 at 3:38 p.m., allows, in counties excluding Maricopa, Pima, and Pinal, any licensed or certified dental provider that meets access prescribed qualifications to provide dental services to a member who is eligible for the service. With that, I'd be happy to answer any questions.
Any questions for Jessica?
Madam Chairman?
Yes, please,
Just
Senator
a
Yee.
question regarding the amendment on the 10 miles where the supervising dentist would be located from the practicing dental therapist. How did we come up with 10 miles?
That was me coming up with 10 miles, Senator Yee. I just wanted to have a dentist available within a certain distance that could get there if they needed to go. And the way the bill is written, they don't have to have any supervision. They can be on their own, except maybe through a phone or something. So I thought 10 miles would be close enough. Somebody could come there. I imagine 20 miles would work too. 20 miles would. But that's how I just thought 10 miles was close, 10 minutes away.
Thank you. And since we have rural areas in Arizona, 10 miles actually could be 20 minutes. It could be 30 minutes. It could be longer. So just keeping that in mind.
Depending on where the roads are, you're right. Okay. All right, Jessica, thank you very much. We'll call for the sponsor, Senator Bartow. Oh, she's probably doing another one of her bills somewhere.
She's coming, but she said
Okay. She's what?
she's coming, but she said she could start.
Okay, all right, very good. Then we'll start without her. We'll start with those who are wishing to speak. We'll start with Kristen Bolini. And Steve, if you'll be my timer, please.
Yes, ma'am.
Okay. Thank you for being here.
Thank you, Madam Chair. Good morning, committee members. For the record, my name is Kristen Bolini, and I'm here on behalf of Dental Care for Arizona. We are a coalition of 16 organizations that have come together to support dental therapy as a way to provide additional access to dental care in rural Arizona, underserved populations across the state. As you mentioned, Senator Yee, yes, Arizona is a big rural state, and I would agree with you. 10 miles could be 20 minutes, it could be 30 minutes, depending on the roads. I've talked with all of you quite a bit about this proposal, and I know you've heard a lot from the other side on this proposal, so I'll try and keep my comments brief. Dental therapists have been safely and effectively providing care around the world since the early 1920s. all of the conversation about dental therapists not being safe, dental therapists not being well trained, dental therapists not being efficient and effective providers in our communities doesn't stand up to the evidence. The evidence indicates that dental therapists are safe and they are effective. They are safe and effective in the communities in the U.S. where they're working. They have been working since 2004 in Alaska. They've been working since 2011 in Minnesota. They are working in Washington State, and they're working in Oregon. Madam Chair, I did deliver in the packets that you've gotten. I delivered these to your offices yesterday as well, but I put an extra one in the packet in case you don't have it with you. But what we have done is taken a look at the education requirements in statute for dental providers. The reason that the bill indicates that a dental therapist must go through a CODA-accredited training program through an accredited college and university, but we don't specify a degree that will be awarded, is because in Arizona, in our statutes, we don't specify the degrees that are awarded. So for dentists, it is the determination of the dental school whether or not a dentist has to have a baccalaureate degree before they start dental
30
school.
seconds.
So I wanted to bring your attention to that. Our intention is to have CODA accredited programs training dental therapists. We believe that that is the gold star standard of education and training. We believe that dental therapists trained through CODA standards, and CODA would not have adopted standards had they not believed that that training protocol would prepare these dental therapists for the scope of practice that you see in the bill. Madam Chair, I'm probably down to 10 seconds, so I'm gonna wrap up and just say, in Scottsdale, Arizona, there are 481 dentists. In the communities in northern Arizona, Coconino, Yavapai, Gila, and Navajo counties combined to serve 530,000 people spread over almost 42,000 square miles. You have 280 dentists. So we do have needs in rural communities, whether you're a private pay individual, whether you have dental insurance, or whether you're on public insurance. You have trouble finding a dentist in those communities, and that's what we're here to try and address.
Thank you very much. Any questions? All right. Thank you very much.
Thank you, Senator.
Let's go to Kevin Earl, speaking for the Arizona Dental Association against the bill.
Thank you, Senator Allen and members of the committee. For the record, I'm Kevin Earl, Executive Director of the Dental Association. We represent about 2/3 of the practicing dentists here. We have made no bones about our concerns about this model. We do not believe it's an effective answer to address the issues that affect most people that are out, particularly in rural areas. We believe that there must be a much more targeted approach to identify exactly why it is that we don't have healthcare professionals going into those areas. We did a study, the American Dental Association did a study that said that 90% of the Medicaid population in Arizona is within 15 minutes driving time of a Medicaid dentist. That's been criticized by the proponents, and it addresses the fact that we believe that the networks are challenged, and that there is, and we brought to the attention of Senator Allen the concerns that dentists are having trouble getting credentialed by Access. With respect to the academic training, I'm going to defer to, we have Dean Brad Smith from Midwestern University, our largest dental school here, who can address the issue that Kristen Bellini just mentioned about the qualifications for entry into dental school. He can talk about CODA accreditation. He can talk about the expenses. There are enormous expenses associated with
30 seconds.
With that. And I'd also like to introduce, we have 2 dental students here. One is from Senator Allen's district, who would like to talk about his own experience living in rural areas and his intention to return to those areas. And with that, I'd be happy to answer any questions.
Any questions? Thank you so much, sir, for being here, and thank you, and we'll call up the students that you're wanting to have speak. I'm doing every other person, so we'll go to James McGonahan. Is for the bill, and he wishes to speak. Not here? Okay. We'll go to Linda Guzman. Lydia, I'm sorry. Lydia, yes. She's in favor of the bill. And I keep forgetting to tell people, be sure and always state your name for the record. Thank you for being here.
Thank you, Madam Chair. Good morning, members of the committee. My name is Lydia Guzman, and I'm with Chicanos por la Causa, and I stand before you to read a statement on behalf of Chicanos por la Causa's Board of Directors in support of SB 1377. On behalf of Chicanos por la Causa, CPLC, and its Board of Directors, we support dental therapy as an innovative solution to address Arizona's access to oral health care challenges. We believe that dental therapists can help expand access to oral health care, particularly in rural Arizona. Dental therapists are safe, effective, lower-cost providers who can be embedded in the communities they serve, providing accessible and culturally competent dental care. As you know, CPLC works diligently to help build and strengthen communities, promote healthier populations, and enhance economic opportunities here in Arizona and across the Southwest. Dental therapy is a fiscally responsible way to increase access to dental care for the communities that we serve. We all know that a good education is critical to the future of our children. Yet here in Arizona, 56% of Hispanic third graders have a history of tooth decay, a figure well over the national average. We also know that dental disease is one of the leading causes of school absences and contributes to children's inability to concentrate in school. Now, the reasons for this disparity are complicated and many, but our state must begin to take the steps needed to address this chronic shortage of care. Adding dental therapy to Arizona's oral healthcare system is a viable way to start addressing these disparities and needs. SB 1377 is critical to developing a dental care delivery model that will provide more access to affordable oral health care in our communities and across the state. We ask you to please support this proposal. Thank you for your consideration.
Thank you, Lydia, for being here. Thank you.
Madam Chairman, I have a question for
You have a
Ms. Guzman.
question? Yes, please.
Thank you, Madam Chairman. Thank you, Ms. Guzman. First of all, I agree with you. I do believe that the populations that you have addressed are critical to being served. And it's unfortunate that some of the access providers are not in those areas, if that's the case. Some of the populations that we are talking about under this bill have the most acute dental problems. And I'm concerned that when we're providing just anybody, we are actually giving them substandard care, not the best quality of care. So how would you address that?
Yes,
Madam
please.
Chair, Senator Yee, what I'd like to do is I'd like to yield that question to someone who's more expert in that area. So, if I can.
Who would like to answer that question? There's somebody?
Well, if they're
If
on the
not-
list to speak, maybe they can
Yeah, if
address
you're
it.
on the list to speak, then we'll, are they on the list to speak? Whoever she'd like to call up?
Very good.
All right.
I am on the list to speak, but I've already spoken. Thank you, Senator Allen. Senator Yee, the studies that have been done on dental therapists from across the globe and the dental therapists in the United States prove that dental therapists are safe for their limited scope of practice. So the complex procedures that are of concern and the patients who have very complicated and complex needs, those complex needs are not going to be handled by a dental therapist. A dental therapist can perform procedures that are the most common basic procedures, fillings and those types of things. They can dispense medication. They cannot prescribe it, but they can dispense antibiotics for abscessed teeth, those types of things. And the way the collaborative practice agreement is written, the dental therapist will refer any complex procedures to the dentist. So anyone who has those high-level needs you're talking about will be referred directly to the dentist versus the dental therapist. That 80 billable procedures, many of which are x-rays, education, nutritional education, how do you brush your teeth, those kinds of things, all of those things the dental therapist can do, but any of the complicated needs would be taken care of by a dentist.
Thank you. And Madam Chairman, and this isn't for any of the speakers, just to share from the Health and Human Services Committee, we did hear from Dr. Robert Rhoda, who is a periodontist in the Scottsdale area, and he said when he was practicing as a general dentist early in his career, he was doing an extraction. The extraction can be done under this bill by a dental therapist, and the extraction looked to him to be one of the easiest extractions you could ever imagine, with a sort of a wobbly tooth in a squishy tissue, and it would have just been pulled out probably by the patient in any other situation. But because this patient was in the chair, he pulled out that tooth, and immediately the blood just kept flowing, and in fact it shot out across the patient's feet on the chair of the dental clinic chair, and it was just something that was not expected. He did not know that going in as a general practicing dentist. That could happen in the situation of a dental therapist under this bill, because they are able to do extractions and surgical procedures. So I just wanted to put that on the record.
All right, thank you. Thank you, ma'am. All right, Michael Stanley. Is Michael here? All right. He had put in that he's against the bill, but he wanted to speak. So, Paul Smith. Oh, I'm sorry. Did I say your name wrong? No. Michael Stanley. Oh, you just were daydreaming. Okay. Welcome.
Thank you for having me. I am a first-year dental student at Midwestern University, and I am an Arizona resident of life and plan on spending my life here. I would just like to respond to maybe some of the things that have been addressed, and reemphasize that the answer to underserved communities' healthcare issues wouldn't be a undereducated physician or dentist in this situation. I can speak personally from I recognize the problem. I'm very concerned about underserved communities. I purposely studied Spanish in my undergraduate to be able to further my abilities to serve underserved communities within Arizona. I would also point out that in my family, we had a personal experience where we were in La Paz County, in an underserved, what could be considered an underserved community, and my father suffered an accident and injuries in it, and he succumbed to those injuries in the hospital. And I would not, I don't pretend that he could have been saved by anything. You never know in medicine. But the answer wouldn't have been a less educated than a doctor in that situation, a less educated healthcare member. There was time due to the lack of doctors in the hospital, there was time between when he was seen and when he showed up.
30 seconds.
And I would just like to emphasize that undereducated healthcare members are not the answer to underserved communities' problems. Thank you. I can answer any questions.
Thank you, and I'm sorry for your loss, and I understand the pressures that are going on in our rural areas with getting adequate health providers, and it is a challenge.
Yes, and I didn't come for a sob story, strictly to point out the dangers of undereducated.
But I'm happy to know that you want to go back and serve your community and stay in the state and maybe serve some of these areas. That'd be great. Thank you.
Thank you.
All right. For the bill, let's see, Mary Begay. Oh, here's the sponsor. You may now come up. Senator Bartle, welcome.
Thank you very much, Madam Chair and members. I appreciate your working with me as we're dealing with other hairy issues in Jude. So I know a lot of you on this committee have heard all of the issues over and over again, and we probably already know where our votes are. And I appreciate that. I think, it does deserve a lot of consideration when we become another state moving in this direction, because it's a movement, and if Arizona is going to join it at this point, we will be considered one of those that will be plowing the way for other states. And I think, for one, that's one reason why there's so much opposition in this state for this bill at this time. Having said that, there are just, I just want to reiterate why I'm supporting the bill in three specific reasons. I think it's been well established, the need's been well established. Lack of oral health care at an affordable rate throughout the state. I also think it's been well established that through many surveys and reports that dental therapists are well trained. Now I know our bill increases the direct supervision hours, and I completely agree that that's appropriate to make sure that Arizona does this right. But what I think we need to make sure to keep in mind is that they truly are, number one, that they are safe and effective, and we need to look at the results of states that have used dental therapists over the years in terms of establishing their safety and effectiveness. I just want to quote a couple of things from on that point. Since 2004, dental therapists have increased access to care for 45,000 Alaska natives living in 80 rural communities. And in Minnesota, dental therapists have been serving patients since 2011. Dental therapists have been used in more than 50 countries for nearly 100 years. And I want to quote a past president of the American Dental Association Council on Scientific Affairs from the Journal of American Dental Association from January 2013, who says, "The results of a variety of studies indicate that appropriately trained mid-level providers are capable of providing high-quality services, including irreversible procedures such as restorative care and dental extractions." Furthermore, the Minneapolis or Minnesota Department of Health has, in their January 31st letter, indicated the same. As part of tracking, quote, "We know that dental therapists are now distributed throughout Minnesota's rural and urban areas in proportion to the distribution of the population at large. About 35% of DTs work in community-based, nonprofit, faith-based clinics or community health centers, federally qualified health centers." Quote, "The body of evidence supporting dental therapy shows that dental therapists are a lower cost provider that can improve access while providing safe, high-quality care." The second thing I wanted to mention is that it will save Arizona money and under access and in those that are not on access. I think we've put a lot of emphasis on this increasing access's responsibility. But let's remember that access does not cover preventive and regular care except for under Altex. It only covers emergency dental. So it's not going to, this isn't the answer for that. Access will not be responsible for covering a lot more dental care. But those that are low income will have that access through other avenues like community health centers, and dental therapists will be a lower cost provider, just like PAs and nurse practitioners are. Now those that are covered 100% under Altex, those are people in skilled nursing facilities and other long-term care facilities. Access will save money by being able to get to those people. They've indicated that the provider rates will be lower, just like they are when they reimburse PAs and nurse practitioners, about 80 to 85%. So more of those that do have coverage under the Altex population will receive better care, and it'll be at a lower cost. Those people will not get care now under the current scheme through a dentist.
To that point, Senator, they'll get better care, but if you're saying already that access does not cover that care, so then how do they get better care? Who's paying for that? The federal government through their grants? Or how are they going to pay for that better care?
Thank you, Madam Chair, and I appreciate the question. They will get the preventive care that they need through a dental therapy model. A dentist that has a vision for expanding their practice model using dental therapists will be able to send them to skilled nursing facilities and other places where there's a need, do that preventive and restorative care that they are trained for, and they will be reimbursed under access, and those people will be served just like we had envisioned when we passed that bill not too long ago. Instead of waiting for the $1,000 emergency coverage that all other adults are covered for, they're going to go to the emergency room and get that care at a much higher rate, generally.
All right, but to that point again, access right now isn't paying for that preventive care. But if we pass this bill, now access will pay for the preventive care.
That's a great point of clarification, Madam Chairman. We do cover all techs, the long-term care population, totally,
Right.
from preventive to emergency.
Correct.
And so access is responsible for that care. And so in delivering...
All techs is the older population.
It is.
So now we're talking about the total other population, and you're saying for this preventive care, they don't pay for that right now, but they would through, if we do this bill.
They do through all techs now. So dental therapists would be able to save the state money and deliver that care at a lower cost.
Oh, okay. So you're saying, Senator, that you're talking about all techs. Okay. Now, what about the rest of the population where that need will be filled? Who will pay for those care centers? Who's paying the bill there?
Well, I think, Madam Chair and members, we've heard a lot from community health centers that they deliver care to everybody, whether they are an access patient, whether they're a low income, whether they have insurance. And so it is, according to the history of what's happened in Minnesota, these people are getting more and better care at a lower cost through that model. Community health centers are a primary example of how this can work efficiently in Arizona and effectively.
Madam Chairman? Just for the current model that we have, which is less of a cost to the patient and to the access system, we have critical care services for preventative care in the hygienist category. Hygienists provide that preventative care. And in the model that we have here before the bill, or even in our current system, a hygienist would be charged less in that access system than what you would charge for a dental therapist. So that is not a deficiency in our current system.
To that point, Madam Chairman, I really appreciate Senator Yee bringing that up. They certainly do. Dental hygienists and and the other mid-level oral professionals can deliver care to these populations effectively, but they can't do as much as a dental therapist can. And so, they can do those 80 procedures that are so necessary and needed, and they can do that without supervision. After their training, they are under that dentist license, and they are out in the field performing that work, meeting those populations' needs, and they're doing it effectively at a greater reach of the dentist. The third thing I just wanted to leave you with was the economics of this. I think we have to admit that somehow the current structure of dental professionals feel threatened by this. And I wonder why, out of their opposition to throwing a lot of stones and accusations at they're not trained and they're not efficient, they're not whatever. I think it might come down to there's a little bit of a threat there that this business model could supplant what they do. I think it's not accurate. That hasn't been the experience in Minnesota. But we do have to look at the fact that some dentists really do. Their business has expanded because of their use of dental therapists. They've made money, and they continue to see that as a personal success in their heart, reaching out to the communities that they want to serve in a greater way, using dental therapists, and also a monetary one. I would just leave you with this. Why would we stand in the way of that? If they're safe, if they're effective, and the business model can accomplish what we all want in this country, and that is people to prosper, employ others, I don't understand why Arizona would want to stand in the way of that.
Any questions? Yes.
Thank you, Madam Chair. Senator Bartow. We touched on it earlier, but tell me again, if somebody goes in for a procedure that a dental therapist can do, but if a dentist did it, could the dentist charge more for that procedure if they did it as opposed to if a dental therapist did it? So would a dental therapist charge the exact same for the procedure as a dentist, or would they charge less, or do you know that?
With the dentist, or would a patient?
Yes. So, Madam Chair, if somebody wanted to get a procedure done that a dental therapist can do, that of course a dentist can do also, if they went into a dentist's office, or when the dentist did one of those procedures, is the billing rate the same if I went to a dentist that got that done as opposed to if I went to a dental therapist that got that done? Would I see a decrease in expense if I went to a dental therapist for the same procedure? Am I paying the dentist more for their expertise for the same procedure? Is it the same? Is it less? I just don't know.
Well, Madam Chair and Senator Smith, I think in reality, whether it's if it's a Medicaid reimbursement, the expectation is it would cost less to Medicaid, and if it was private, there would be a natural lower compensation for the dental therapist who's getting compensated by the dentist.
And unless somebody knows that,
dentist.
Because I would equate it to a doctor and a nurse practitioner. I know that I'm going to pay the same amount when I go to get something done at the doctor's office if I'm seeing a nurse practitioner or a doctor. I just don't know if the same model is here. Am I going to pay less for the same service if I'm using a dental therapist, or am I going to pay the same as if a dentist was treating me? So, again, somebody knows that, if I can just get that answer at some point in time.
And Madam Chair,
Sorry, I don't know your name, sir. What's your name?
maybe there's someone who could speak.
What's your
to
name,
that.
sir? Chris.
Thank
Chris is standing behind you, Senator Bartow, and so we'll let him answer that.
Madam Chair, before the sponsor leaves, I just want to make one comment, because as you were talking about the concerns that are raised, there's a business saying that the pain of change is forgotten when the benefits of that change are realized. And I think sometimes when we're looking at this, there's always a pain of change when we're looking at our career field having a disruption. But when we look at this, the potential profitability for the dentist as well as benefits for the communities, I think that clearly, that saying clearly applies here. The pain of change is forgotten when the benefits of that change are realized. And I think there would be some great benefits realized.
For the record, Chris Vineyard, I'm the Chief Liaison with Access. So, Madam Chair, Senator Smith, to answer your question, you are correct. So we essentially, if this is passed, which it is a policy decision, I haven't signed in, so I'll do that after this, but the mid-level provider, when we look at nurse practitioners, physicians assistants, those types of providers, when we look at reimbursement, when the same services are delivered to our members, the reimbursement, according to our fee schedule, is less. And so it is a way to incentivize participation, ensure we have enough MDs in our system to meet the need of our populations. But that is the fee schedule. That's not to say, based on some of the concerns with network sufficiency, that the health plans may find it wise to reimburse a little less or a little more in some instances, depending on the need in the communities.
And Madam Chair, I think that's what my question is going to as well in the network. So in the private practices, so I don't know if there's a practicing dentist here that they can say, hey, if I had a dental therapist who did XYZ extraction, if they did it, it would cost X, but if I did, it would cost Y. And so that's what I'm trying to figure out. I can't imagine it would be a different rate, though, in a private practice.
To answer, Madam Chair, Senators, but to answer that question, so in these instances where there might be a contractual arrangement between a provider, so an affiliated practice, dental hygienist being a prime example, it's all dependent really on who's delivering the service. And so if you go into a dental office where the dentist is overseeing the practice, but a DHAT's providing the service, they are responsible for that service being delivered. So it's our expectation, based on the submission of a claim, that the reimbursement be tied to that person delivering the service, so it would still be less.
Okay. Thank you.
Okay. I saw a hand there, sir. Are you signed in to speak? Okay, if you'll come up and state your name.
Madam Chairman, nice to meet you.
Thank you.
I go by Brad Smith, but I'm signed in as Paul Smith because Paul's my first name. I won't get into why I got called Paul and Brad and all that kind of stuff. So I was a practicing dentist for 22 years. I've dealt with third-party payers, cash payers. If I can just address, Senator Smith, your question and respond to that. First, it's a free market society. So as a dentist, if I want to charge $10 for something and the dentist next door charges $20, I can do that. Third-party payers are going to reimburse based on their rate, and right now with preferred provider organizations and HMOs, they're going to pay no matter who the provider is. Most associates or dental therapists are going to work under there, and dentists are used to working with dental associates or associate dentists, and in other states, dental therapists. A lot of times, the office bills as one office. So there isn't a distinction. Even though technically there should be a distinction, there isn't always a distinction because you have to get signed up on the plans, and so sometimes the office itself will sign up on the plans. So the bottom line is no. There wouldn't be a difference until Access makes a change specifically targeting dental therapists as getting reimbursed at a lower rate. Right now, as it stands, no, that would not be the case. So I'm here to speak in behalf of...
Madam Chair, sorry.
Yes,
go
ahead.
So the rate's the same, whether you do it or
right
if
now,
you
the
had
rate
a
is
dental
the same.
therapist do it, I would be charged as the patient the same amount whether you did it or a dental therapist did it.
Right. So the example is in my office, I had 3 hygienists. So whether I did the cleaning or my hygienist did the cleaning or I took the x-ray or my hygienist took the x-ray, it was all billed at the same rate.
Thank you.
Okay, so now you can go ahead and start your statement because we were asking you a question.
Great, thank you.
Simon, please.
So I'm going to just address a couple of issues in the time that I have based on the educational model. So under CODA standards, and our school right now is preparing 1 year from now to have a site visit team. And so it takes about a year to 2 years to address all the CODA standards because there's so many. But I want to address just a couple of things right now. Competence. So we have, at our school, we have 29 competencies, and a competence or a competency is when one student does one particular procedure to a level that they can do it on their own without supervision. To get to that competent level, to get to that competent level, there needs to be a number of procedures. As I look at the number of hours that the current dental therapy proposal has is 400, even at 1,000, but 400, that would be 10 weeks or at 40 hours a week, or approximately 50 to 100 procedures total out of that 80 that they could do. So the possibility of them doing multiple procedures and gaining competence is really absurd. If I was the site visiting team on the initial site visit, I would say immediately, I'm going to give you a recommendation. You don't want a recommendation when you have a site visit. I'm going to give you a recommendation. You change your 400 hours to at least 1,500 hours. So that would be my initial recommendation. in order to get repetition enough to get competence so that they would be safe to the public. CODA's number one priority is to make sure graduates of the accredited programs are safe to the public. And that's also my priority as a dean, to make sure my students are safe. So I'll see our students, and they'll have 4 to 5 experiences, and then they'll want to test or challenge a competency. And we'll look at that, and that's the bare minimum. Usually it's 15 to 20 experiences before we feel that they're competent to actually work on the public without supervision. Second thing I want to address is just the cost. So the cost of establishing any kind of program that's going to have beyond hygiene up to dental education, the full scope of dental education, is going to be somewhere to start at about per year, per student, $10,000 for supplies, $100,000 per student per year for allocations, might be the FTEs, the support staff, the psychologist, business services, and then about $500,000 for capital expenditures. This kind of matches what the Minnesota model has, and so if you look at that, then it's going to be about $2 million to $20 million to run a program, and it's going to be about $120,000 for total tuition to $150,000 unless the state wants to kick in money. And if the state kicks in money, they could lower that tuition fee. Third thing I want to address is, and I'm probably out of time.
Yeah, but our timer's not timing.
Is the last thing about, we're just finishing the admissions process at our school. I can tell you that there is not one school in the country, dental school in the country, that would say, oh, you don't have to have a bachelor's degree, but then leave it open-ended saying, well, you could be 1 year in college or 2 years. Usually what it is you're one class short of getting a bachelor's degree.
And thank you. A question. In the comment that the dental therapist will bring the cost of dentistry down, and I think that's kind of in reference to those who are providing in rural areas, maybe on reservations or in whatever areas in rural Arizona where there's a need, and in our community health centers and all that. It's going to drive the cost of that down, but still keep the quality of service high. And I wonder what your opinion is on that. I have a couple of questions to ask you about that there.
Okay, that's a loaded question, by the way. So would it bring it down? Depends on what the overhead of the facility is and what funding they're going to get. So if they're funded and the dentist doesn't have to be responsible, or dental therapist doesn't have to be a responsible facility. Obviously, costs could come down if the owner of the facility wanted that supply and demand, fiscal responsibility. So that's neither here nor there. The quality of care is going to be dependent really upon the individual. And the demands that the corporate sponsor is going to put upon that individual. That's where your quality is going to be.
Well, let's talk about the corporate sponsors, because I know one of the models is that there's a corporate that has the dentist, and then they hire the therapist, and then they, that's how they run their business, is with the therapist. The dentist then has the liability, I would assume. In the bill, there's all these memorandums of understanding, collaborative agreements that the therapist does with the dentist, but who's ultimately is going to have the liability in this?
Well, all parties would be sued. So all parties would have the liability. It would be whoever had the deepest pockets when you went to either discovery or trial or settlement or whatever. It's going to be whoever has the deepest pockets. The dental therapist is probably going to have the shallowest pockets. And so, yes, are they going to be named in a suit? Would they be liable? Yes, they'd be liable. But the dentist, and then if there was a parent company, a corporation, obviously they'd have the deepest pockets.
Would the dental therapist, will they be paid by the piecework that they're doing, or a salary?
Right now, associates in DSO, dental service organizations, are paid both by piecework as production and a base salary. So I would assume that dental therapists would be paid a base salary. They could be paid piecework, especially when it came to pediatric care. A lot of pediatric care is very profitable, especially in Texas. And so they'll get the pediatric patient under IV sedation, and they'll do 20 procedures on the patient for $6,000.
And but that could not be a therapist do that. Are they allowed to?
No, but they could
the
do.
procedures I read, they wouldn't be able to.
Right, they could do multiple procedures on a pediatric patient.
Okay, but you
Not
have to
under
have a
IV
dentist
sedation.
put them under, correct?
If they were going to do IV sedation.
They would
yeah.
have to, and then they could do the work after, okay.
Yeah.
Would you, well, that brings up a good question. If, in my amendment that I'm trying to do, because I read through the bill about the supervision, they're supposed to be under supervision of a dentist, and yet down at the bottom it says that a dental therapist may practice dental therapy procedures authorized under this article in a practice setting in which the supervising dentist is not on site. I wanted to amend that they have to be on site, but then it brought problems really to rural Arizona, which is why I put the mileage in there so somebody could get there at least quick enough if there was a problem. So if you were going to be in a practice where you're going to be putting somebody under, I guess the dentist would have to be there. I can't see how the dentist would walk out and then let them proceed to do some work on a patient that there isn't a dentist there who did the procedure to put them under. I mean, it just brings up these questions. You wonder how it will typically iron out.
So if I can address
yeah,
that.
go ahead.
There's really no way in a double-blind study without going through all the lawsuits to see how many problems there has been with dentists or dental therapists in an individual setting across the country. There's just no way to be able to really, really tell that honestly. But I can tell you that having a pediatric patient in my chair, I can give them 2 carpules, so 2 shots, and kill them. If I don't understand everything there is to understand about their physiology, biochemistry, whatever system failures they might have, I can give them 2 shots and I can kill them. I'm not talking about IV sedation, and that has happened with 2 injections.
So, sir, in your in teaching, so how many times does a student have to, before they're allowed, to then get their license, how many times do they have to go through those procedures, and how how much time is put into that to understand working on children?
So not just preclinically, but clinically, and working on children and adults, our students go through about 3,000 hours of clinical care under direct supervision of either a general dentist or a specialist.
Okay, and so in my amendment where I'm trying to up the education, I was so alarmed, and I'm going to be handing this out to my members here, which shows the education. If you'll pass that down, because I'll give more address to my amendment later, but I just want to ask you a question, but I might as well let them see what I'm talking about. I actually modeled it after what Vermont was doing. Do you have one? Okay. And that's a high school diploma, 3-year dental hygienist program requires licensure, then CODA accredited dental therapy program and 1,000-hour supervision. And even Minnesota, if you do the advanced therapist, they're wanting a high school diploma, bachelor's degree in dental therapy, master's level advanced dental therapy program, 2,000 hours supervision. That's for their advanced therapists. So ours was so low at high school diploma, associate degree from CODA accredited dental therapy program, 400 hours. I couldn't see how possibly, with all the procedures that are listed in the bill, that they would have enough qualification to be able to do, safely what they're going to be tasked to learn to do. And so I want your comment on that.
Okay. So first, I'm going to say that I've worked by and beside many dental therapists. And I can tell you, because the comment's been made that we're really opposed to dental. I don't take a stand from the university or setting, but I've seen some excellent dental therapists, some horrible dental therapists, some excellent dentists, and some horrible dentists. So it comes down to the individual. It really does come down to the individual. But as far as the training goes, 400 hours and a high school diploma, with a high school diploma under CODA accreditation standards that demand rigor and excellence in academic standards, I don't see them being able to understand biochemistry, physiology, neuroanatomy, to be able to then to put it together with pharmacology so that they understand all the medications, all the system failures, the diabetes, the cardiovascular systems, that they're going to be able to understand that. Now, could they understand that at the advanced therapist level? Yeah, I think that, I mean, honestly, I think they could if the program was taught correctly. At this level, if I was on the site visiting team, I would recommend them on that as well. I would say there's no way that your students that are matriculating could possibly understand unless you dumb down the information. And so I want to see your assessments. I want to see every PowerPoint, every lecture, every test question that you have. I want to see the results of every test question, so the outcomes. And then I'm going to make a judgment whether I think they're safe to treat people.
Okay, thank you. I just wanted to know if my amendment's a good amendment to increase the education level, and maybe that's not even enough there for the safety that we're talking about. Thank you very much. Do you have a question?
Thank you. And it does go to your amendment, Madam Chairman, and to Dr. Smith. Dr. Smith, right?
Dr. Smith.
Yeah. And so I wanted to ask you, on the amendment, it does say 1,000 hours. Is that right, Senator?
Yes, 1,000 hours.
And so in your testimony earlier, I thought I wrote down that you thought 1,500 hours was sort of a safe level. That would fall short, obviously, of what we see in the amendment.
I would say, well, the DHATs in Arizona, I looked at their clinical hours, and they're about 1,600 clinical hours. And so I'd say with the reduction compared to a dental school, they don't need to have 3,000. I went to a 3-year dental school, by the way, the only one in the country. And we had 2,400 hours of clinical care. And it was rigorous to be able to get through all the program and that, and we had a bachelor's degree. So I would say, yeah, you could do it with 1,600 hours.
Madam Chairman, and going back to the questions you were talking about for pediatric patients, but in the bill, page 21, subsection E, it talks about where you have the supervising dentist not being on site with the dental therapist. And while the amendment does add that they be within the 10 miles, it doesn't remove the language that says the supervising dentist who is not on site does not have to have previously examined the patient or rendered a diagnosis. And earlier you were talking about the pharmacology and all of the very important issues for a doctor to be able to understand with that patient in their medical history, or in this case, the dental history. Wondering how you feel about that language there, because it is saying there really is no relationship between the supervising dentist who isn't even on the site, where the dental therapist is actually performing the potentially irreversible surgical procedure.
So I've been in the same room as a dental therapist that's taken a tooth out, and they didn't take an X-ray. And so there's no diagnosis other than the patient said, I have pain up on this side. And so we don't know if they got the right tooth or not. Fortunately for that patient, they got the right tooth, but they left a root tip in and didn't go back and get the root tip because they didn't know how to do that. That doesn't mean that that's one case scenario. Can I leave you with one case, though? So I was in practice for 2 months, and I saw a little 6-year-old boy. The mom brought the little 6-year-old boy in because this tooth down here, the first molar, pediatric first molar, did not erupt, and all other 3 had erupted. So I took an X-ray, and the first X-ray I saw, there was a little halo above the tooth, which usually is kind of referred to as a dentigerous cyst. But there was something that I saw because I had a lot of oral pathology training, and I thought, I'm going to take a different X-ray. I took a different X-ray, and I noticed the borders were different, and it looked like squamous cell carcinoma. I referred the patient to the oral surgeon. They took a biopsy. It was squamous cell carcinoma. We saved the patient's life at 6 years old, but lost his mandible, this half of the mandible, at 6 years old. I'm not so sure that the current bill would be able to address someone to that competence.
Well, and what your testimony is helping me to understand. This isn't, the dentist's concern about this bill, to me, and those I've been talking to, is not about that they're threatened with their business. What I am hearing from the dentist I'm talking to is they're concerned about the care and the level of education so that the care can be done properly. And that's where it's coming from. It's not being afraid you're going to lose your business or that. And so I think in defense of the dentist community coming out against this bill, what I've been hearing in my conversations have been about the safety issue, and that's why I tried, and why my amendment is trying to address that, trying to get us to have these therapists have more training so they can be successful. We're going to pass this bill in our state. We want it to be safe. And when you talk about little children, and I know Congressman Gosar talked to me twice, quite lengthily, and that whole conversation was about safety. It was not about being threatened over loss of business. And I think that you're helping us to understand that this is serious and that we need to be sure these individuals have the education so they can be successful and we can have it come out the way we want. And frankly, I think my amendment doesn't go far enough. But anyway, thank you. Any more questions? Okay.
Thank you.
You're welcome. Let's see. We have in favor of the bill, Deb Gollett. Well, she's neutral, but do you want to speak? Yes. Thank you for coming down. 2 minutes. 2 minutes, yes.
Madam Chairman, I wanted to speak on the other amendment, the Any Willing Provider Amendment.
Okay.
Is that okay?
That's okay.
Can I have this handout for you all? Thank you, Madam Chairman. Members, my name is Deb Gullett with the Arizona Association of Health Plans. I'd like to share with you 2 concerns we have about the Any Willing Provider Amendment. First, the potential for added costs. This week in the Appropriations Committee, Director Betlach shared with the members this chart that I've given you that shows all 50 state Medicaid programs in 2016. Our yearly average cost per member was $5,867. In New York, it approaches $13,000 a year for their Medicaid population. A robust managed care system is one of the main reasons for this cost differential, and in Arizona, we've had a robust managed care system for 35 years. We have had previous legislative discussions regarding any willing provider issues. 2 years ago, the Arizona legislature considered a bill that would have allowed any willing pharmacist to fill Medicaid prescriptions. At that time, we found national research studies that showed a move to an any willing provider model would increase the annual costs of the benefits by as much as 6 to 10%. Our annual dental costs in Arizona, our annual spend in the Access program alone is $150 million, so we know there's a lot of money at stake. And I just want to finish my one sentence and tell you what we learned in the Yuma project. So there was a pharmacy in Yuma that had lost their Medicaid contract to a national chain that came in and said, we'll give you lower rates. And that's our job, to negotiate the best price we can get for the taxpayers. But rather than cripple a local pharmacy, the health plans got together with the pharmacists, we renegotiated the deals, and everybody's working. So my point is that we have an opportunity to work with our providers on our networks, and we've got a great model, and we hope that you will let it move forward. Thank you. Sorry. I timed it out, too.
You did good. You did good. Thank
Any
you.
questions?
Any questions?
Madam Chair.
Yes, please.
So my question is, how did the providers solve that problem in Yuma?
Madam Chairman, Senator Brophy McGee, in Yuma, we came together and we talked about it. The health plans didn't want to put a local pharmacy that had been in business for 50 years out of business, so they found a way to renegotiate their prices, and now Medicaid members in Yuma can get their prescriptions from both pharmacies. Because it's not just about the money. It is about the money, but it's not only about the money. It's also the quality of care that our members get. Thank you, ma'am.
Thank you. All right, let's see. We about moved through all the, okay. We had him. We have a, John McDonald, do you want to make a comment? Not necessary, Madam Chair. Okay, thank you. Any of the necessaries, if you feel so inclined. If not, I don't think it's necessary, that are listed as necessary. You would like to speak, sir? Come on. Yes, I'm sorry. What is your name?
Brennan Hancock.
Oh, thank you. I see your name here. Okay.
Thank you,
Sorry.
Madam Chair. Good morning, Madam
Good morning.
Chair and members of the committee. My name is Brennan Hancock, and I'm a third-year dental student at Midwestern University. I grew up in the White Mountains of Arizona in a rural community of less than 4,000 people. My mother is a first-grade school teacher, and my father is currently self-employed after losing his job in the logging industry when the industry was stopped in the late 1990s. SB1377 hits home. This bill is geared towards the demographic I call my own. At age 10, I needed extensive dental work done, which was a financial sacrifice for my family, as it was right after my father had lost his job. This work included multiple crowns, root canal therapy, and extractions of grossly decayed teeth. These were not easy or simple procedures, and the dentist that did it was extremely well trained. I speak to you today, 17 years later, with those crowns still in my mouth. That same general dentist extracted my wisdom teeth, saving my family time and money of having to go to a bigger community to be treated by an oral surgeon. There is no way I personally would trust my 10-year-old child to anyone less qualified. The rural communities need care, but they need highly trained care. I was not the exception. I would say the majority of my classmates growing up suffered from the same problems that I did, many of whom were on access at the time and had the opportunity to be cared for, but did not seek care. These children needed expert care. Sending practitioners into rural communities that are not adequately trained will be a disservice to the population. The rural population deserves to be treated by professionals that are highly trained and qualified just as equally as those in larger communities. I have done everything in my power so far to be able to return to one of these communities after I graduate. My plan as of now is to open a practice and to see access patients, as well as working with the National Health Service Corps to open my practice as one of their sites and provide the best care that I can to this area. I am being highly trained to care for these populations, many of which rarely see any other form of medical professional on a regular basis. We are the first line of defense to many life-threatening diseases. There are 4 others that I personally know in my class right now that want to return to rural communities, but due to the constraints of sustaining a dentist in these small communities, many cannot. There's no shortage of people that are willing to go to rural communities in the dental field. Quality as well as the expertise of providers needs to be top priority. It is not justifiable to condemn rural communities to inferior quality of care. Thank you, and I'd be happy to answer any questions.
Thank you very much. Any questions for, yes, please, Senator.
Madam Chair, that was very compelling testimony. Thank you very much.
Madam Chair, thank you, Senator McGee.
What community are you live in?
I grew up in St. John's.
Yes.
I have deep ties to Snowflake as well as St.
Yeah.
John's. My family's been in the area since the late 1800s.
Very, very good. Thank you for coming.
Thank you,
Appreciate it.
Senator.
All right, I think that's the end of our testimony. Oh, yes, please come up. I might have missed you, or it's not on here. Your name, sir?
My name is Daniel Preston. I'm from the Tohono O'odham Nation,
It's on here.
tribal nation, and thank you, Madam Chair, for giving
You're welcome.
me this opportunity to speak. Again, my tribe is the land base is 2.8 million acres, 4,460 square miles, and we have 30,000 plus here in the state of Arizona. Our population, and as compared to Navajo, 400,000 tribal members. So the 10-mile amendment that you spoke of greatly doesn't fit the needs of our tribal nations. We have 3 clinics and 1 hospital. And right now we have an issue, a problem of maintaining and retaining health professionals on our reservation in our tribe. So there's a disparity there, and so no one faces more significant challenges to accessing dental care than those living on American Indian reservations. Arizona is home to 22 sovereign tribal nations with over 390,000 tribal members living on and off the reservation. We all know that the direct link between oral health and overall health, what is happening in our mouths, affect our bodies. Oral health is linked to healthy birth outcomes in pregnant women. It is critical to proper nutrition, and oral health of our children is critical to their future. We know that the best way to give our children a bright future is through giving them a good education. Yet tooth pain is one of the leading causes of school absences. When children suffer from tooth pain, it is more difficult for them to concentrate in school and to learn what they need to be successful in life. It affects their quality of life, their self-esteem, and ultimately their future. The first tribes to utilize dental therapy were in Alaska, where remote communities had little to no access to dental care, as has been mentioned. And so we share that disparity as far as it's like an hour and a half away each way on our reservation, our rural communities, that we are able to get to a dentist. So I'll end with this. Please support this legislation. Help us to make dental care accessible to our tribal communities and help us address the oral health crisis. Thank you.
Thank you. A question. On your reservation, do you have a dentist there now at all?
Yes, we do. And
okay, could that dentist not then be the supervisor over these therapists so that you have somebody in case you've heard of some of the examples of emergencies that could possibly happen, and so you would, would that not work if you've got somebody there already? Huh?
They're not within 10 miles.
10 miles of what? Oh, go ahead, sir.
Yes, just that on that note, the 10 miles, again, in order for tribal members to get to, again, we have one hospital and 3 clinics. 2 clinics have dental plus the hospital. And again, it's hard retaining those health professionals. And again, it's at least an hour to an hour and a half to get to each facility in each way. So if we're talking about amendments, I mean, I think this would really be in countering, the amendments would be countering what we're trying to accomplish in the bill. However, I think some possible willing to work with the committee or yourselves in the committee to come up with something that
well,
more,
yes, we could maybe address that. Originally, I was wanting to amend it to that the dentist had to be on site. If they're working under somebody, then that's where they need to be. But you're saying that you're willing to have these therapists come on your reservation without any oversight, close oversight of a dentist, because they'll be miles then away from any, help. Now, I realize, again, from what I heard in our working group, people who might have illnesses such as diabetes, the therapist wouldn't work on them anyway. Right. So it seems you're going to have dentists on your reservation, that's a need that you're going to still need. Otherwise, they're going to have to leave and go other places to get some of that help. So if they're there, they could supervise. That's what I'm thinking. But the other point I want to make, but we could work on that. The other point I want to make, though, seems to me that the reservations need to grow your own dentists and doctors and somehow have a program. Maybe you do. Maybe there's programs out there where you are sending your young people to medical school or to dental school. So you get that, and then they come back and work 5 years to pay for their education. Those are the kind of programs we need that can really help the reservations.
Right, and you're correct. And I as far as the advocacy for preventative, so that, and you talk about diabetes because we're the second highest prevalence in as a tribal nation. And so, looking along those avenues to, as far as education, we are doing that. But again, our disparities with health and education are still on our agenda, where we're trying to address what we can do to help our tribal people.
Okay, thank you very much. Any other questions for the gentleman? Thank you. And
thank you.
Ma'am, I see that you're wanting to speak. Back there.
Oh, there's a couple.
Good morning, Madam Chairs and members of the Education Committee for the Senate. My name is Majeline Begay. I'm a enrolled Navajo with the Navajo Nation. I reside and employed on the Navajo Nation. On our nation, we have 4 hospitals and 7 clinics throughout our nation. And so we have extended vacancy for dentistry. Many dental chairs are empty, within the new health facilities that we have. And we do not attract dentists to come out and work after a loan because of the remoteness or either ruralness, although we have a abundance of beauty with the landscape within our nation. And there's no private dentist practice on our nation. And so for to get a dental appointment, individuals would have to get to a health facilities 7 a.m. and if they want to be guaranteed to get on an appointment, they have to be there 5 or 6 a.m. And so the profile of our Navajo Nation is that the Navajo Nation has one of the worst dental caries in early childhood caries, which is the number one chronic disease in our Navajo Nation. And so grown our own, we're being proactive, we're trying to do something about it. With that, the tribe has trained for CHRs with some of the help that we had from other resources in Arizona and elsewhere in Community Dental Health Coordinator. And we're also did a MOA with the University of Arizona where they're training some medical providers to address the shortage in medical providers. And we have advocated for an increase in dental program within the Indian Health Services. And this issue is recognized by American Dental Association, where they're helping us to address this issue. Our tribal council passed a resolution on March 9, 2017, supporting the dental therapy, and that we have a newly Navajo Department of Health, where we have an Office of Regulatory or Quality Assurance, and we're getting ready to provide licensure for all the individuals within the Department of Health that needs licensure, also standard of care, competency skills checklist for all the paraprofessionals that we have in our department. And we're also working on expanding the community dental health coordinators.
Ma'am, your time is up. If you could wrap up, please.
So in closing, that's the Navajo Nation, and we hope that you support this bill. Thank you.
Yes, please. You accept.
Madam Chair, members of the committee, thank you. My name is Deb Kappas, and I am a dental hygienist, and I have over 20 years of dental hygiene education experience. So I've taught in dental hygiene programs for over 20 years and have been involved in the CODA accreditation process a number of times. And I wanted to address, I appreciated Dr. Smith's testimony on the CODA standards and the quality of education, but I wanted to clarify a few points because I think he might have left you with not the most accurate impression. He referred to 400 hours as if those were the hours of clinical practice that a dental therapist would receive in their education, and that is not the case. Those 400 hours or 1,000 hours is after graduation. So the clinical hours of clinical practice within a program is not stipulated in the law, nor is it stipulated actually hour-wise in CODA standards, just like it isn't stipulated in CODA standards for dentistry. However, our model curriculum that is based on CODA and has taken into consideration the level of competency that does have to be attained and the number of procedures reflects about 1,200 hours of clinical practice on those limited number of procedures in a model curriculum. Now, that's not to say that any program that gets itself up and running doesn't look at it and says, we need more than that, because it is up to the educational institution to assure that they can address those clinical standards. If I want to read to you right from the clinical standards in an intent statement on the clinical practice for dental therapists, recognizing that there is a single standard of dental care, the care experiences provided for patients by students should be adequate to ensure competency in all components of dental therapy. That is what educational institutions are charged for. That's what CODA requires. That is what will happen. So thank you,
Thank
and I'll
you.
take any questions. I have a couple other comments about
I
safety
don't
if
think
you have
it
any questions.
will be as, I think with what is proposed right now is not sufficient to reach what you just read. I really don't. I believe that we need to ensure that there are more hours and especially some pre-work, you know, that would come through taking biology classes and things of that, prerequisites. So I don't agree that with what is proposed in the bill is going to get us to where you think we're going to get with a highly safe group of therapists. And I think if that's our goal and we want them to be well trained, there needs to be a little more education added to that. That's why I proposed the amendment.
Madam Chair?
Yes, please.
I just have a question, because I see on the handout that you gave, and I've seen this multiple times, but it stipulates a high school degree, but then it also has an associate's degree from CODA accredited dental therapy program. From your testimony, it sounds like, and let me also say that the third bullet point on that is 400 hours supervised clinical practice, which is after that CODA training.
Yes.
So it sounds to me like what you're saying is to achieve that CODA training, that's nowhere near the 400 or maybe not even near the 1,000 that are in the amendment.
It will typically be, if we're looking at model curriculums, it will be more than that. It will be substantially more than that.
Okay, and Madam Chair and Deb, so when we're really looking at this, we're looking at, one, the high school degree, but then also those hours that will basically be through all the training to get them qualified to take care of, I think it's the 80 procedures that they're qualified to take care of.
That is correct.
And then after that, after they've been qualified for those 80 procedures, then it would be either the 400 or the 1,000 hours, in essence, working under a dentist.
True, that is correct.
Okay.
That is correct.
And Madam Chair, just because of your experience, what are your thoughts on those hours after working under a dentist before they're actually allowed to go out on their own? Do you have an opinion on that?
I can see the value in that, particularly not so much to increase competency, although repetition always increases, your skill level. We always get better over time. At least we hope we will. But I think there's great value in having working with a potential supervising dentist who's interested in entering into that collaborative agreement with that dental therapist in order for that dentist to understand the skills and limitations and abilities of that dental therapist, and also then to determine how that working relationship is really going to end up out in the community and achieve its goals that it wants to achieve. So it's a great way to develop that relationship. Now, how many hours that actually takes, who knows?
Madam Chair and Deb, just out of curiosity, would 400 hours do you think would be sufficient? I mean, if we're looking at, a 40-hour week,
right?
That's only 10 weeks,
right?
Does that give a dentist and a graduate student enough time together to actually?
Probably, it might be dependent upon what the intentions of the utilization of that dental therapist are. Who are the patients they're going to see? Where are they going to see them? And truly, is that scope not all the 80 procedures, but maybe that scope is actually even more limited. So it's difficult to say. It might work for some, it might, and others may need more. Specifying a minimum in law is not a bad idea, given that, and in reality, I suppose that if a dentist wasn't quite ready to let their dental therapist go out and practice without their close supervision, that they would just say, well then, in the terms of our collaborative agreement, it's still going to be direct supervision. So that's still all up to the dentist. It still comes down to the dentist to ensure that.
Madam Chair and Deb, that's the way I read the bill too.
It's exactly right.
And I look at this as the dentists are going to be, in essence, in control of this situation. They have to trust that therapist to actually be at that place. So that's why originally, Madam Chair, I was okay with the 400 hours, and I was a plumbing contractor, so we had apprentices and we had journeymen and we had people and some people that had journeyman licenses that I wouldn't let run a job just because they weren't ready. But again, as I see it, and it sounds like you're reading it the same way, if a individual,
Right.
Because they have to work under a dentist, if a dentist didn't realize or didn't think this individual was really equipped to send them out on the reservation an hour and a half away, they would still have the authority to say, no, you need more hours.
That is my understanding, and I think that's very appropriate. I think that's the way it should be.
Thank you.
But I very strongly believe it needs to be stated. That's why my amendment asks for more hours.
Oh, okay. Got
My amendment's asking for 1,000 hours supervised, like Vermont. They ask for 1,000 hours supervised clinical practice because these procedures are, they need to be sure they know all those procedures well. So.
Yeah, I feel flexible about those hours. I think that's a good conversation to continue to have as to what is the appropriate number of hours.
All right, thank you.
Madam Chairman, I see
Yes.
the sponsor here. I just have one other question because
Yes.
she left earlier. Thank you.
She has a question for the sponsor. Thank you very much. Okay.
Thank you.
Thank you, Madam Chairman. Thank you, Senator Bartow. I was wondering if you can please comment on the amendments being offered today and what your position is on both the First and the Second Amendment.
Thank you for the question. I appreciate that, Madam Chair and Senator Yee. As I understand it, the Second Amendment is the one that requires any willing provider by access. That one, I think, is probably unworkable and will kill the bill. But I believe that if it's important to have the discussion and have the bill move forward with that discussion in mind. I'm supportive of both amendments. The First Amendment, I don't think is necessary, but again, I think if these are good discussions to have. I think the 1,000 hours, I don't have any problem with that because I think that is Arizona specific. I think we can live with that. I think that's appropriate. And I think that's a good, agreeable place to compromise. And again, as was stated, dentists have to feel really comfortable with the number of hours and with the procedures and with the population that they serve. So, it's a good starting point. The 10-mile, I think, is problematic. But again, I think it, and because of the business model, the model of dental hygienists working not under direct supervision so that they can fulfill their purpose. I think it's a bit problematic, but I think it's a good conversation to have going forward, and we can live with that. So I'm supportive of the amendments at this point. I hope that answers your question.
Thank you, Madam Chairman. And while you were gone in the other committee, there was a discussion by the Dean of the School of Dentistry at Midwestern who indicated that 1,500 hours additional for the dental therapist is a more comfortable number that he would be at. Would you be open to increasing, if this amendment is adopted today, from 1,000 to 1,500?
Madam Chairman and Senator Yee.
Madam Chair, I think, wasn't he talking about the training that would fit on the Dakota? Because I think there's a difference there.
No, I don't think so.
No? Okay.
I'm not sure. I think, all of the provisions in terms of training should be discussed as whether or not they are relevant to the safety of them, of dental therapists. And if we can come to a place where we can agree and remove opposition over those things, I think that's a discussion I'm willing to have. If it's just an arbitrary raising of the limit in order to make it more difficult to get dental therapists out in the field and doing what we really want them to be doing inside of this business model, then and it might be a little more difficult to move in that direction.
Sure. Madam Chair, to
Yes, you may.
that point, My concern is, and again, coming from a contractor background, I've had different people work for me, and some with different skill levels. Some, I trust quickly. Some I don't. And for me, I look at this as, because it's under the dentist's direction, I trust those dentists to be able to say, if there's a quick learner there, if this person is ready to be sent out and they're capable and the community could use them, it becomes a win-win. If we legislate and put a cap that you've got to have this many hours, we're in essence saying, just like a gifted student, you've got to go through 9 months of this. Well, some kids can learn it in 3. So I think the more we put on a limit on that, and again, I'm not opposed to the 1,000 hours, but if we keep jacking that up, what we're doing is actually limiting the dentists, not just limiting the therapist. Because if a dentist wants to use that therapist and he's serving a reservation area, and this person is fully equipped, but he just can't send them out because the state has said you have to have 1,500 hours, I think that's arbitrary. And I would rather leave it to the discretion of that dentist, because they are going to be having the responsibility. They've got a financial responsibility on that. I know for me as a contractor, I was going to be responsible for whatever this person did. And so I think it's the same for those dentists. So I think we have to be careful that we don't put a restriction on those dentists and don't trust them to know who they're working with, to know their capabilities, and to know whether or not it's appropriate to send them out or not.
Madam Chairman, just one additional question. And when former Senator Barbara Leff was the Health and Human Services Chairwoman, I remember she had this bill. It was called Truth in Advertising, to a certain extent, in the medical field. And what it would allow the patient to know that they may be being seen by someone other than who you might expect. So if they walk into the clinic with a white coat, that you can't just expect that person is a fully trained licensed dentist. Does this bill contemplate that the patient being seen in the chair knows that they will be getting a mid-level professional doing that surgical extraction, or will they just assume that the person walking in will be the dentist?
Madam Chairman, Senator Yee, I think that's an excellent question. I think they should know. I think a patient should know. And it should be incumbent upon the dentist or whoever's making the appointment with the patient to ask the question or make sure the patient is informed of that opportunity to be informed.
Thank you.
We can, I think, if it isn't explicitly addressed and another statute does not cover that instance, when we can look at that, I don't see any barrier to adding that disclosure to the bill.
Thank you.
Thank you. Any other questions?
Madam Chair. Yes. Thank you, Madam Chair and Senator Bartow. I am confused. You indicated that the Second Amendment would kill the bill, but you were okay with it going on? I'm confused.
Madam Chairman and Senator Brophy-McGee, I believe it's going to be problematic for access to accommodate that policy. It's a big policy decision. Mm-hmm. And I think, it did come up briefly as a concern in our stakeholder meeting, but we didn't really get into how it would actually be workable. And the immediate response by the health plans was, this is not workable. So I think, from my perspective, I don't think we know enough in order to say this would be workable in the bill. But I understand it's a concern that we can continue to get a clear answer on. So if Senator Allen is more comfortable having that discussion going forward, I'm fine with having it as well.
I'd like to talk about that amendment, if I could, for a minute. I believe that many of the problems we have in rural Arizona concerning being able to get the adequate care we need is because in rural Arizona we have a high percentage of people that are on access and don't have their own private insurance. And so when we limit the providers, we limit the ability of rural Arizona and these individuals to be able to get the care they need. And so then we come back and say, well, rural Arizona doesn't have any care, so we have to come up with different ideas and different programs like we're doing with this to try to find the need to get care for rural Arizona when it's being artificially, it's being made through these programs where we're having to come up with the money to fund access and to fund and keep the rates down and so on and so forth. And that same and so,
Madam Chairman,
yes,
can I
go ahead
address
if you want to address that.
quickly? And I brought it up at the beginning of my comments earlier. Right now, our access program does not cover dental for adults.
I understand that.
Except for a limited population, all techs, and if Senator Yee's bill passes, pregnant women. So I'm not sure if this is a if what you're saying is correct or not. But what I am saying is that with dental therapy, the population we're after is not necessarily access. It's access for low income that are not eligible through community health centers, through tribes, and some for
the tribes would be SMI, right? Which
and
is
some
still
for emergency, with that $1,000 cap for emergency dental. Dentists would be able to hire dental therapists to accommodate them.
Okay, so why I get a little frustrated is it's being promoted as a way to get out there and provide health care for rural Arizona, and the people you're talking about, a lot of them already, because they're on access and they can't afford their own health care. I don't know, it's like this going around in a merry-go-round about who we're targeting and the reservations and all of this. The reservations are going to be paying it through the federal government or through access. On the reservations, it's not going to be a private business taking private money. It's going to be doing it through government programs. And but part of my frustration, but if you want to finish your thing, and then I'll do my before we vote on the amendment. So go ahead and finish your remarks, and then I'll do my thing.
Well, just to that that comment on the reservations, I think Senator Peschlakai may want to address some of that. But from what I understand, the community health centers, as I also treat all patients, no matter the payer source. So it's not all access, not all Medicaid, not all INS or IHS. So what we are striving to do is to reach the uncompensated, the uninsured, the low income in those rural areas. I think primarily through a community health center or federal qualified health center. And
I do really support community health centers are great, but the vast majority are paid through some sort of grants, tax dollars, federal, local, whatever it is. A small percentage of people that go through there actually pay. There is in a lot of those health centers. So,
and to that point,
some of them do, some of them don't, but most
the
of them.
Christian clinic, neighborhood clinic, just down the street on 19th and Van Buren, they have dental care. I can see them hiring dental therapists in their practice so that they can serve more people. They charge $20. These people are not on access. Many of them are not citizens, but they still pay, and they serve them out of the goodness of their heart. And so, I mean, I can see it benefiting a lot of people that are not on government programs as well. So,
and
thank you.
I do agree with you on that point. All right, thank you very much. Any further? All right. All right, then we need to. Yes, Senator. We've kind of talked this to death. So 2 minutes.
Thank you, Madam Chairwoman, members of the committee. For the record, I'm Senator Peschlakai of Rural District Number 7 up in northern Arizona. And I just have a really unique story that I want to share with you. About 10 years ago, one of my younger sisters in Cameron she wasn't around anymore. And I always wondered what happened to that young lady, Raylene Dixon. And this dental therapy bill came up, and I put it on Facebook, and she contacted me. And she says, "Sister, I'm up in Alaska. I'm a dental therapist on the tribal nations." And she says, "You need to get this dental therapy done in Arizona because I want to come home." And so my thought is, as a former Workforce Investment Act director up in Flagstaff, this will just provide more opportunities, more industry, and fill a niche in the communities. And it's similar to when we as women had been giving birth over the years, that niche was filled for doctors by midwives. And so it goes hand in hand. And my sister, Raylene, has never been in any trouble with the programs, the dental therapists that are trained on tribal nations, and they take a lot of pride in their work. And on the tribal nations, there's a lack of housing. And so we do have trouble recruiting and retaining good doctors. And so if some of these local folks can go to dental therapy school and take care of their own, it's a good thing. So thank you. Yeah, thank you for hearing the bill.
Thank you. Thank you for your remarks. All right, members. I just want to make a comment about the amendments. One reason why the access amendment, or that willing provider, I see something going on in our health care because maybe of my age or whatever, but it is getting critical in that we cannot get the type of care that we're really needing. Yes, we have, I'm going to talk about the medical for a minute. We have PAs and we have nurse assistants. We have all kinds of nurses. We've been ratcheting down and doing different things to try to get the needs that we need out there. But what we really need to start focusing on as a people is keeping highly trained surgeons and doctors and dentists in the field, and they are under a tremendous amount of pressure. And when it takes me 6 months for me to get in to see a GI doctor, when my son-in-law is having a kidney stone attack, is in an emergency room at a hospital in Scottsdale, and the urologist will not come and see him, we have got some problems. I can get in and see my nurse assistant and my PA all the time. You can go to, when you have flu and you have those kinds of ailments, you can go find help. You can go find help for that. It's out there because the market is pushing towards those kinds of services, those lower level services. But when you need a heart doctor and you need other kinds of help, you're waiting months and months for that because we put so much pressure on the top end of it. And Obamacare, I blame on the hospitals and the insurance companies and the pharmaceuticals, because they've all come out smelling like a rose. But it's the doctors who are getting beat up and leaving their practices, and a lot of it is because on the mountain, and I'm really irritated over this, when people are willing to practice on the mountain and the insurance companies will not let them be in their network, you force them out of my mountain, and then I don't have services that I need. The insurance companies need to be covering any doctor that is willing to be a provider anywhere. And that's kind of what this amendment was all about, is making my statement that we're destroying our healthcare system, and we come up with ideas of, well, let's have dental therapists. That's how we can get need out there to all the people, because we are going to ratchet it down. The costs are going to come down. The training is going to come down, and somehow we'll get them out there. Okay, we'll get dental therapists out there. They'll be all over, just like our urgent cares are all over, where you can all go get an urgent care anytime you want. But when you want a dentist that's got to do a root canal, you're going to have a hard time finding them, because you're going to see students switch into therapists because it's much simpler and they can get to work much quicker. And that's how we're artificially pushing this whole system. That's my opinion. And so that's why for that amendment. But I will drop that amendment, the amendment for access, because I see I'm not going to get anywhere with it anyway. But I still feel like we've got to focus on how do we save our surgeons and our highly trained professionals and how we get people to continue to go down that path, because that's who we need, and we need our dentist. But I highly am telling you right now, I am sticking to that we need more education on and my other amendment I'm very passionate about, and I hope that it passes. And so, Madam Co-Chair, if you will move the bill and then move the five-page Allen amendment.
Thank you. And Madam Chair, for the record, I will not be offering the second amendment, correct?
Correct.
Okay, Madam Chair, I move Senate Bill 1377 with a due pass recommendation. I further move the 5-page amendment in your name dated February 14th, 2018 at 2:43 p.m. be adopted.
Okay, you've heard the motion on the 5-page Allen dated 2/14/18 5-page amendment. All those in favor say aye. Aye. Those opposed, nay. The ayes appear to have it, do have it so ordered. And now the bill as amended.
Thank you, Madam Chair. I move Senate Bill 1377 as amended with a due pass recommendation.
Okay, we've heard the motion, no more discussion. Let's have the vote. Yes,
Madam Chair,
you may.
very briefly, and this is my third round on this, and my teeth are killing me.
You gritting your teeth?
So, I realize the amendment is not what some folks want specifically, but I think it does represent what I've been talking about all along, is trying to come up with some attempt to negotiate terms. So I think that's a step in the right direction, and hopefully those negotiations can continue as the bill moves forward, which I'm assuming it will. So I vote aye.
Senator Gray?
Aye.
Senator Miranda? Senator Smith?
Madam Chair, explain my vote.
Yes, you may.
Thanks, Madam Chair. When I first heard this bill, it was the two questions I asked was, can dental therapists open up their own practice and compete directly against a dentist that I think would take work away from a dentist and I think would usurp the role of dentists play, and it does not. It does not allow that. And the second thing is, it's under the purview of the dentist. If the dentist thinks dental therapists are a bad idea, don't hire one. And that's kind of how I just boiled it down. Now I get it. There's some more nuances, and maybe you have the practice of potentially rogue or bad dentists hiring. I think you still have that possibility today. It's almost like we do in a lot of stuff. You can't regulate against bad people all the time, like the opioid bill. We're gonna pass all the laws you want. You're a bad doctor. You're still gonna do bad things and break the law. So I think it's needed. But Madam Chair, I appreciate your attention to trying to strike a compromise with some of the other sides too. But I vote yes.
Madam Chairman, may I explain my vote?
Yes, you may.
Thank you. The critical issues that we have to weigh in policy discussions, particularly on dental therapy, are really weighing access to care versus the highest standard quality of care. And we want to ask the question, do we just let anyone perform dental procedures like irreversible surgical extractions, especially to lower income, less educated families? Under the bill, you only need to have a high school diploma. And some additional hours that we heard today from a dean of a Arizona dental school, he said were not enough. Well, I agree that we need to continue to address access to care issues at every corner of our state. This bill proposes that dental therapists be allowed to perform irreversible surgical procedures out of the presence of a licensed Arizona dentist. And the bill also authorizes that the dentist does not have to be on the premise of that dental therapist procedure or even have rendered a previous diagnosis of that patient, no patient history. Those populations being treated under the bill would have the most acute dental problems, but yet they'd be treated by individuals with very limited levels of training. I worry about the populations who will not even know that they aren't even being treated by a trained and licensed dentist. Particularly in our most vulnerable populations, they deserve the best, highest level of care, no matter where they live or where their zip code is. For the highest standard quality of care and for patient safety, I vote no.
No.
Aye. By your vote of 4 ayes, 2 nays, and 1 not voting, you've given Senate Bill 1377 as amended a due pass recommendation. Your bill's next. Okay. We're going to hear Senate Bill 1473 next. Michaela?
Madam Chair and members, Senate Bill 1473 establishes a state seal of civics literacy program to recognize students who graduate from a participating school district or charter school and who have attained a high level of proficiency in civics. The bill requires the State Board of Education to collaborate with ASU's School of Civic and Economic Thought and Leadership to adopt a list of assessments to determine civics proficiency, and requires the seal to be affixed to diplomas of students who meet the requirements outlined in the bill. Madam Chair, there is one amendment I can explain.
Please explain.
The three-line amendment in the chair's name, dated February 14th, 2018, at 11:28 a.m., directs the State Board of Education to collaborate with other experts on fundamental civic knowledge and literacy at other state universities in addition to ASU. With that, I'm happy to answer any questions.
Any questions? Thank you. Okay, Senator Bartow.
Thank you, Madam Chair and members. For the record, Senator Nancy Bartow, District 15. And I really appreciate all of the work being done on this issue, including Senator Yee's bill that passed earlier on. I think it highlights the need for attention on this issue. And I appreciate staff's involvement too, both in the House and Senate. Cody's been very helpful, as well as the Department of Education. You know, when only 36% of respondents could name all three, according to studies, can name all three branches of the government, only 27% of Americans know it takes 2/3 vote of the House and Senate to override a presidential veto. 75% didn't know the function of the judicial branch. 71% are unable to identify the Constitution as the supreme law of the land. 73% couldn't correctly say why we fought the Cold War. 44% were unable to define the Bill of Rights. And 6% couldn't even circle Independence Day on a calendar. I think, you know, it's no wonder that one of the first bills that we passed under Governor Ducey was the Civics Education Initiative. What this bill will do is take this opportunity to become more proficient in civics to a higher level. And it differs from the Civics Education Initiative in that it's completely voluntary, but it's student-driven, and there's an incentive involved. There's no money attached or needed, frankly. But the incentive is for a student to learn at a very high level more about civics in our government in order to become a more responsible and effective citizen. And I think we can all agree that that's needed when we look at the level of attention to this this course of study in our schools, both public, and private, and charter, all of them. And so what this does, it allows the state, it mandates the State Department of Education to award a seal of proficiency to a student's graduation diploma upon completion of a program that would be designed in conjunction with the State Board, with the School of Civic and Economic Thought and Leadership at ASU, and other civic experts that have that kind of expertise in Arizona colleges and universities. And so that's basically what it does. It doesn't mandate that schools do this, but it allows students to do this. And I think it's a good compliment, actually, to Senator Yee's bill, because hers is more school and district-driven, whereas this is more student-driven. So I think we're hitting both ends of the spectrum and allowing an opportunity for students to really learn what it means to be civically educated.
Thank you. Any questions? And I agree with you. I think it's a perfect match for Senator Yee's bill. Senator Smith.
Thank you, Madam Chair. Thank you, Senator Bartow. Am I reading this right, that they only need to attain at least a 2-point grade point to receive this proficiency seal?
In their Madam Chairman and Senator Smith, in their regular studies, yes.
And so, Madam Chair, this would be an additional course on top of their social studies and other courses as well. And if they So how do you get the seal? So you have to get at least a 2.0 in all your potential civic courses, and then this would be another course?
Madam Chairman and Senator Smith, yes.
And Madam Chair, so what type of proficiency do you have to show in this separate new additional course in order to obtain the seal?
Madam Chairman and Senator Smith, that will be determined in coordination with civic experts at ASU through their school and others, with the department and or with the board. And so those assessments would be determined with those experts, and would be a high expectation of knowledge.
And so, Madam Chair and Senator Bartow, I think my slight problem is if we are wanting a high expectation, achieving a 2.0 and the other ancillary classes that go with it, to me, is not setting the bar all that high. And if I'm going to be able to get a new accommodation, a new seal, a new something that shows I'm so far and above my knowledge in this particular subject area, and I get it, there's a separate one on your regular course studies, did we just arbitrarily come up with a 2.0 grade point that deems proficiency, or do we use this in other areas that's the benchmark?
And Madam Chairman, Senator Smith, you're the first one that brought that up. I don't think we wanted to limit a person's ability to earn a seal where they achieve a lot of knowledge in civics education by not allowing them to achieve that seal and still maybe skate by on their American history courses. But you bring up a very good point. And I'm going to give that some thought. I think that's a very good thought. Maybe we should look at raising the bar there as well.
And Madam Chair and Senator Bartow, that would just be my recommendation. Again, if you're going to go above and beyond and have some kind of a separate recognition that somebody's done so well, getting a C, to me, does not live up to that merit. But that would be my only suggestion. Thank you.
And there's a vision, Madam Chairman and Senator, that this kind of program could grow, where a school, a high school, or an entire school district could also earn a seal as a school or a district in terms of how many of their students achieve the seal. So, we can work with this concept in the future, and maybe at that point we can look at whether or not 2.0 is an appropriate standard in order to earn the seal.
And Madam Chair, real quick, if I may, when we did the civics test, I think we needed a D, 60% to pass that. Now that was for all students, though, to at least have, the ground floor knowledge of civics. This, to me, is on a separate scale. If you're going to say I am so exceptional and I've attained something even higher, again, I would put a higher benchmark on it, and so I get it that the districts can kind of mesh and form this course, but the underlying language in the bill that they can't mesh is the 2.0. So I would hope that you would consider at least a potential amendment in the future to raise that to a minimum of a 3-point would be my suggestion. Thank you.
Okay. Any more questions for our sponsor? Okay, I don't think anybody wants to speak on this bill. People have signed in to support, so please register that. All right, then, if there's not any more comment, let's go ahead and move this bill.
Thank you, Madam Chair. I move Senate Bill 1473 with a due pass recommendation. I further move the 3-line amendment in your name dated February 14, 2018 at 11:28 a.m. be adopted.
Thank you. You've heard the motion on the amendment, 3-line Allen amendment. All those in favor say aye.
Aye.
Opposed, nay. The ayes appear to have it. Do have it so ordered. The bill as amended.
Thank you, Madam Chair. I move Senate Bill 1473 as amended with a due pass recommendation.
Thank you, and let's call for the vote.
Aye.
Senator Gray?
Aye.
Senator Renda? Senator Smith?
Aye.
Senator Yee?
Aye.
Senator Kennedy?
Aye.
Senator Arnett?
Aye.
6 ayes, 0 nays, and 1 not voting.
By your vote of 6 ayes, 0 nays, and 1 not voting, you've given Senate Bill 1444 as amended a due pass recommendation. We will now go to 1442, personal finance. Brandy. Just a minute. I was going to say this. Members, we've got 5 bills left, or no, we have 4 now. 4 bills left, so we've got to do it by time floor comes. Okay.
Madam Chair and members, Senate Bill 1442 establishes the State Seal of Personal Finance Proficiency to recognize students who graduate from high school and have attained a high level of proficiency in personal finance. It requires the State Board of Education to adopt minimum requirements for the program and requires the seal be affixed to diplomas of students who meet the outlined requirements. Additionally, it allows the State Board of Education to consider the establishment of a required separate personal finance course for high school graduation. With that, I'd be happy to answer any questions.
Any questions for Brandy? All right, thank you, Brandy. And Senator Yee.
Thank you, Madam Chairman. I'll make this brief. I have long been an advocate for personal finance for students, and one of the first bills that I sponsored in the House was to ensure that our state standards in the social studies section have the financial literacy be a part of that forevermore, because it was always done, but it was based on the the desire of that State Board of Education when they were always revised. And so now it's an exciting time because the State Board of Education is in the process of adopting revised standards, and the financial education is going to be a part of that. So this goes in line with how our students will be looking at personal finance and financial education. I do have a couple of speakers, I think, who are here today and who have been very patient, so I'd love to hear from them.
Hey, Cynthia. Jane. I was just going down the line. It was Cynthia's first. But go ahead, Jane. Welcome.
Thank you, Senators and all the members of committee. Allow me, and thank you, Senator E. invite me to be here to talk about this subject. In U.S., even we are one of the richest country, but people are suffering from money issue, and we are pursuing for the democracy, but we become the slave of money. So financial education is very important especially now only 5 states, they have financial education. So my company, World System Builder, we have the mission to get people educated. By 2020, we want to educate more than 1 million families. And it has to start from like high school student, because they are the people very soon they get into college, and college student now student loan become one of the biggest debt in our country. So we want to not only educate the consumers, we also want to start from high school student, and I would ask senators to put this into consideration that my company, we don't ask for extra funding or a program to run this, but we have licensed people to run this program. We can go to a high school and to do the education. Total is a series of 5 different classes. So if you can put this into consideration and allow us to go to educate people. And of course, the consumers, they are welcome to come to our financial workshop. And we do have every Wednesday night and Saturday morning, we have classes to teach people. And what we teach is from increased cash flow and debt management, building a strong financial foundation, proper protection with building wealth, asset accumulation, retirement planning, wealth preservation. So basically, after learning all these 5 different classes, they can be a better money manager for their own finance. And a lot of people, I take this flyer. Okay, just a minute. I take this flyer to them, explain how important it is to learn all this concept. But people, they don't really pay attention. They think other things are more important. But for people who did really come to learn from the workshop, they thought, hey, why didn't I know this program before? It could benefit me more than waiting until now. And a lot of seniors, they don't even save enough for their retirement. So that's where our mission is. And I do have another speaker who would like to talk to. His name is Michael Shaw.
All right, thank you, Jane. Michael?
Thank you, committee chairwoman, and senators.
I'm a retired engineer. I actually went to school in high school and graduated in Texas, although I got my degree in Arizona State. I was never taught personal finance. I learned it pretty much on my own. And being in this business, I've been talking to a lot of people from 20 years old on up to 60 who haven't got this personal finance. And it's really hard to hear somebody who's 60-year-olds and not having saved up enough for their retirement and dependent on Social Security to live on or go back to work. And a lot of people have gone back to work. So when I retired, I came into this business as a means of sharing what I learned and what I was taught in this business about financial literacy and the need for it. And hopefully I've been able to help a lot of people to learn that. This seal that you're offering to high school students as an incentive for a financial literacy, I think is a great idea, and hopefully we will push it further than that and require specific tests and specific subjects and tests of proficiency to have that. Thank you.
Thank you.
Any questions?
Any questions? You know, I heard a thing coming into work the other day about how America is so in debt, and that people, the majority of Americans, do not have enough money if there was an emergency come up that they could survive for longer than a month. Very few Americans have enough money to do that. So I think this is really worthwhile. Thank you.
May I comment on that?
Yes.
We recommend that every family have 6 months of salary for emergency funds,
right.
So that so we have a lot of basic education that we provide, and we'd be happy to share that with any one of you.
Thank you.
Thank you.
And I do bring a set of books. Would you like to?
You can give it to the page, and they could bring it up here. Thank you. All right. I think we have one other person that wishes to speak.
Cynthia Zwick from Arizona Community Action Association.
Welcome.
Members of the committee, I just want to thank Senator Yee and the other sponsors of this bill. I won't be redundant. I know people are anxious to get to lunch and to the floor. But I do want to say a couple things. One is our agencies work with many of the families that don't get this kind of education, and they struggle to thrive. And so I think this opportunity provides a couple of things. One, the curriculum prepares students to make financial decisions and select financial products going forward that actually encourage their success rather than prevent their success. And the data that Senator Yee included in SCR 1024 about the number of people who have retirement savings, the number of people who have savings of any kind to protect themselves. This is information that we don't. It's not genetic, as was stated earlier. It's not information that we're often getting at home. Many of our parents don't have it. So I think this is really a great opportunity to incentivize that information and long-term to benefit the population going forward. So thank you for this opportunity.
Thank you very much.
I just have a quick question
Yes.
for Cynthia. Cynthia, I was wondering if you have tracked how many, particularly in Arizona, we seem to have a large number of high-interest payday loans, in every corner. And you almost wonder if people who are adults just don't know how to manage their money because they didn't get it in the seats of their schooling. How would you address that?
Madam Chair, Senator Yee, I think you're right on. I think there are a number of predatory lenders throughout this state that rely on the fact that folks don't have the basic understanding about what products are available, how to save money as they go through their lives, as they work and earn a living. I think the other thing is they don't know the questions to ask when they're seeking out products, and so I think there's a lot of opportunities for folks to have access to the alternative products if they knew they were available and they knew the right questions, but also just be in better financial stability so they wouldn't have to rely on a lot of those products. The predatory lenders look for folks who don't have this fundamental understanding, and they look for folks who are vulnerable, and that's their population.
Thank you. Thank you very much. Is that rest of everybody that wanted to speak?
Yes.
Okay. Yes, you have a comment, Senator Smith.
Madam Chair, Senator Yee, my comments on the last bill, would you take those in the same consideration for your bill?
Yes, Madam Chair, if you're talking about the grade level, my bill is different in that the State Board of Education and the Department of Education will determine the proficiency levels, and that is identified in allowing them that high standard. I don't believe that the bill actually says that there's a certain GPA or grade point average that they have to meet. It on page 1, it allows for that delivery to be determined at the State Board of Education level.
Madam Chair, but I'm reading on page 1 on line 39 in that section that they speak about. It needs a 2.0.
Okay. And Madam Chairman, Senator Smith, this was contemplated so that we have the highest level of students who have attained great proficiency in this, not just anybody. And so we would certainly contemplate any type of changes to the 2.0 or higher if we move this bill forward.
Thank you.
Madam Chair.
Oh, next.
Madam Chair.
Yes, I'm sorry.
Since we're discussing, I just want to say, one, I'm a goal-oriented person, so I like to check off tasks and goals to accomplish. And so this was one of my priorities. I think this is a huge thing that we need because so many kids don't have parents that invest in their children financial wisdom. And so this is something that I wanted to see happen, and you did all the work. So, Senator Yee, I want to thank you very much for all that. I think this is a huge benefit to the state of Arizona.
All right, thank you. Madam Co-Chair, let's move the bill.
Thank you, Madam Chair. I move Senate Bill 1442 with a due pass recommendation.
Heard the motion. Any further discussion? Seeing none, let's call for the vote.
Senator Bradley? Aye. Senator Gray?
Aye.
Senator Miranda? Senator Smith?
Aye.
Senator Yee?
Aye.
Senator Brooke-McGee?
Aye.
Senator Ahmed?
Aye.
6 ayes, 7 nays, and 1 not voting.
By your vote of 6 ayes, 0 nays, and 1 not voting, you've given Senate Bill 1442 a due pass recommendation. And what was the bill number you want me to go to?
1066.
1066. I was going there anyway.
Oh, awesome.
Well, that was good.
It's a quick one.
Randy, yes.
Madam Chair and members, the Strike Everything Amendment to Senate Bill 1066 requires the School Facilities Board to develop and implement policies and procedures, ensuring school districts are notified in a uniform manner at least once annually of board services and funding for construction, renovation, and repair projects for school facilities. It also requires policies and procedures be adopted for establishing a project eligibility assessment for all projects submitted for building renewal grant and emergency deficiencies correction funding. It also requires it ensure the maintenance of standardized documentation of projects submitted for board services and for projects awarded board monies, including records of payment to schools that received funding. Additionally, the bill prohibits school facilities board employees from having a direct or indirect financial interest in any property purchase, facility constructed, or contract finance with the school facilities board or other public monies. A violation of this prohibition is designated as a Class 1 misdemeanor. With that, I'd be happy to answer any questions.
Any questions? Yes, Senator Smith.
Madam Chair, how, do we define indirect for the conflict?
Madam Chair,
I don't see it
Senator
as
Smith, no, that's not in the bill.
So I'll have a question for the sponsor then. I can do that now or later.
All right. We'll move to the sponsor, Senator Brophy-McGee.
Thank you, Madam Chair and members. This is a bill that I served on the School Facilities Board for 6 years. I was appointed by 2 different governors, including 1 year or 1 term as chair of the School Facilities Board, and that was back when the deficiencies corrections, all 3 programs were going full bore, and we worked very hard to establish written policies and procedures, some uniformity, some continuity. I am very familiar with the board and believe that there is significant reform that is needed. The Auditor General's recent sunset review audit produced some aspects of this bill. In addition, constituent requests produced other aspects of the bill. I think it's important that we have written policies and procedures when applying for payment for approved emergency deficiencies projects. So this is the start of the reform work for SFB that I'm dedicating myself to, and starting with incorporating some OAG recommendations. In relation to the direct or indirect financial interest, I'm not exactly sure how to answer that question, but I will get you that information.
Madam Chair.
Yes.
Senator Brophy McGee, we contemplated something here a year or two ago with what we thought was a direct or indirect confliction with some of our other folks in Arizona. And so I think if somebody has a brother or nephew who's a receptionist at an XYZ construction place, and that place is tasked to do some work or something on the school, I think by the letter of the law, that's considered an indirect conflict. And what I don't want to do is to not allow that to happen, because there's such a low level. And I think what we used before in that language was it must be in some kind of, the person's family member or immediate family member, it must be in some kind of managerial level or at least some sort of prominence in a particular company.
And thank you, Madam Chair. Senator Smith, what I'm really working in the direction of more, and I am hesitant to put out anecdotal stories, but if you write a specification or approve a type of project that calls for a particular purchase or procurement, that specifies or drives the purchase or procurement or the expenditure of state funds to a certain company that happens to be the only company in the entire state that could possibly provide this exact, that's what I'm looking for. And that's what I want to rule out, but I'd be happy to work with you on it going forward.
Thank you.
All right, any other further questions for the sponsor? There's nobody that wants to speak on this bill, so we can go ahead and move it.
Thank you, Madam Chair. I move Senate Bill 1066 receive a due pass recommendation. I further move the strike everything amendment in my name dated 2/13 of 2018 at 2:49 p.m. be adopted.
All right, you've heard the motion for the striker, 12-page Brophy McGee. So let's all in favor say aye.
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 Opposed, nay. The ayes appear to have it, do have it. So now Senate Bill 1066 is amended.
Madam Chair, I move Senate Bill 1066 as amended receive a due pass recommendation.
Thank you. No further discussion. Let's call for the vote.
Senator Bradley? Aye. Senator Green?
Aye.
Senator Miranda? Senator Smith?
Aye.
Senator Yee?
Aye.
Senator Brophy McGee?
Aye.
Senator Adams?
Aye.
6 ayes, 0 nays, and 1 not voting.
You voted 6 ayes, 0 nays, 1 not voting. You've given Senate Bill 1066 as amended a due pass recommendation. We are now on Senate Bill 1159. Michaelin.
Madam Chair and members, the Strike Everything Amendment to Senate Bill 1159 allows employee leasing firms that contract with a school district to withhold wages for up to 7 business days during their normal 2-week payroll processing cycle, which is what statute currently allows for school district employees. With that, I'm happy to answer any questions.
Thank you. Any questions for Michaelin? All right. This is my bill. And last year, if you remember, we passed Senate Bill 1159, which was to no, that's what the bill is this year. It's 2370 is what we passed last year, excuse me. And, Oh, all right, okay. Anyway, what this, remember that bill last year required school districts to remit employee compensations such as for teachers within 7 business days after the end of the most recent pay period. And our client, and the person on this, the clients that are, the companies that have leasing firms that lease teachers out to districts or to whoever, this bill is putting them on that same pay schedule, because we didn't include them when we said that the teachers needed to be paid within 7 business days. So this Strike Everything Amendment would add employee leasing firms into the statute related to school employee pay to further clarify that such private companies shall also remit compensation within 7 business days after the end of the pay period. This will ensure that teachers, regardless of whether they are actual employees of the school district, will be required to be paid within 7 days in the payroll time periods of the school district and employees, leasing firms will be further in sync. Because they need this, these employee people must have this, trying to read all this, must be reviewed and approved in the same ways as teachers who are employees of the school districts. The ESI payroll demands that. Okay. Any questions?
Nope.
Okay. Any comments? Nope. Well, there might be speakers. I don't know.
Madam Chair, signed in to speak for the bill is John McDonald with Educational Services.
Okay. Thank you.
2 minutes.
All right, John.
Thank you, Madam
Or less.
Chair. Members, for the record, I'm John McDonald here representing Educational Services Incorporated. First of all, I want to thank the Chair for bringing this bill forward and hoping to alleviate this situation. I'll be very brief. Our client is a firm that helps to alleviate the teacher shortage in the state by providing teachers and personnel to school districts on a contracted leased basis, which puts them in the unique position of having to work very closely with school districts around the state in terms of payroll processing. Madam Chair, you summed up the bill perfectly. It simply puts the teachers who are employees of the school district and the teachers who are employees of the private companies like my client, but who work for the school districts on the same payroll processing schedule. They would both have to be paid within 7 days. In order for my client to do that today, they have to have their payroll processing done out of state, because that allows them a little bit more time under the law. If this bill were enacted, and we hope it is, they would then be able to bring that payroll processing function in state, be in compliance with the law. It will put the teachers, whether they are leased or employees of the district, on the same payroll processing schedule. It will sync up the operations in a much more efficient fashion between the districts and our client and other like companies who do the same function, and make the whole system work more efficiently for everybody involved. One thing I want to mention, it does not change the situation for any public school employee. That was the subject of last year's bill. It does not change any of that for any public school employee. It only deals with this unique situation of teachers who are provided on a lease basis. I know that the folks from the Arizona Education Association, who we have talked to going back about 6 weeks ago on this, have expressed some concerns. We would be happy to sit down with them. We think we've tightened the language about as tight as it could be, but if they have language that they think works better, we'd be happy to discuss that. But we hope that we can proceed today. Thank you, Madam Chair. I'd be happy to answer any questions.
Okay, any questions for John? Thank you very much, sir.
Thank you.
All right, Stephanie.
Madam Chair and members, I will be very brief because I'm between you and lunch. For the record, Stephanie Parra from the Arizona Education Association. Madam Chair, we've spoken about the issue. The concern last year was that our employees, we were trying to shorten the window of time that school employees were paid within. So it used to be 10 days for school employees. We shortened that down to 7 days. As a private company, that statute didn't apply to them. Private companies have to pay their employees within 5 days, but as Mr. McDonald said, because they process their payroll out of state, they have a 10-day window to do that, and actually that aligns them with the current statute at the 7 days. So for us, it's if our biggest concern is that this will create a loophole for other private contractors that work with districts to delay pay for employees. So if there's something, if there's language that we can tighten up, I will continue to have conversation with Mr. McDonald.
And I'm open to that, whatever conversations you have. All right, thank you very much. Any other comments? Okay, there's no more wishing to speak, so let's move the bill.
Thank you, Madam Chair. I move Senate Bill 1159 with a due pass recommendation. I further move the 4-page striker amendment in your name dated 2/9/2018 at 11:01 a.m. be adopted.
Thank you. You've heard the motion on the striker 4-page Allen. All those in favor say aye. Aye. Opposed, nay. The ayes appear to have it. Do have it so ordered. Now the Senate Bill 1159 is amended.
Thank you, Madam Chair. I move Senate Bill 1159 as amended with a due pass recommendation.
Okay, let's call for the vote.
Senator Bradley? Senator Gray?
Aye.
Senator Miranda? Senator Smith?
Aye.
Senator Yee?
Aye.
Senator Brooke McGee?
Aye.
Senator Allen?
Aye.
Your eyes are getting quieter as we go.
6 ayes, 0 nays, and 1 not voting. You've given Senate Bill 1159 as amended a due pass recommendation. Last bill, Senate Bill 1378. Brandy.
Madam Chair and members, Senate Bill 1378 requires the informational report for a school district budget override election or the publicity pamphlet for a school district bond election to include a statement of the total amount of revenues that the district received per pupil from federal, state, and local funding sources for that fiscal year. It also allows the district to include any additional per pupil revenue or per pupil expenditure information that the governing board chooses to provide. With that, I'd be happy to answer any questions.
Any questions for Brandy? All right. Members, this is my bill. The purpose of this legislation is very simple. Is to provide transparency to voters and taxpayers by giving them information in ballot pamphlets about total school funding per student as they consider school district bonds and budget override ballot measures. I really believe that Arizonans have the right to know where their hard-earned tax dollars are going from local, state, and federal sources. This bill gives relevant information to the voters. The reasoning for this bill is that voters typically do not know the average amount of money their school districts spend on each student. Now, last year when we heard this bill, it was amended, and there was a pretty cool section put into the bill which will allow school governing boards to provide even more transparency and information to the voters. For instance, if the district has high cost in some areas, such as transportation or a high population of special need children, the amendment, they can tell the voter about these different needs that they have. And the amendment also gives boards the freedom to present to voters and taxpayers the many services the district provides to the children. So that basically is the bill, and if there's any questions to me about it, if not, we'll call it Tom Jennings.
Madam Chair, members, thank you for letting me be here. And if you're getting hungry, I have smuggled some nuts into the. This is how I've been subsisting for the past few hours. So they do go a long way. So I just wanted to thank you again for hearing the bill, for sponsoring the bill, and this is pretty simple and straightforward. I'm not sure anybody on this panel has not seen this already before or possibly sponsored it in the past. So I was looking at the word triskaidekaphobia, which is I don't know if DSM has it chronicled, but it's supposedly the fear of the number 13. And I don't know enough Greek to tell you what the fear of the number $9,600 per child is, but there seems to be a lot of that, and this is something that's really pretty basic that taxpayers ought to know when they go to think about whether they're going to do a budget override, whether they're going to do a bond, whether they're going to vote for a bond. The question of how much does the school district already spend per pupil? Seems to be a pretty basic and relevant question. So it seems like basic taxpayer transparency. We throw a lot of big numbers into these ballot pamphlets, but if you're like me, I mean, I've never seen $35 million in my life or $131 million in my life. I have no idea what those numbers mean, even though I'm okay at math. And so what we want to do is boil this down to a per pupil number. And as the sponsor mentioned, the subsection 4 or subparagraph 14 of the thing offers districts a extremely wide latitude. I'm not a central planner, and I don't think our chair is either. Offers them a lot of latitude to fill in information that they think is important to make context for that overall per pupil spending number. So thank you.
You're welcome. Thank you very much. Chuck. Hi.
Chairman, members of the committee, good afternoon. I know you're very short on time, so I'll be as brief as possible. A couple of concerns that we have about it. Currently, what happens in the information provided to voters for bond, all the projects are listed on overrides, all the specific things that will be paid for with the override are listed. Adding this per pupil revenue amount will cause some particular problems with people maybe not fully understanding, and I'll give a couple brief examples. For example, let's say the district had an override and they're going for renewal of an override. The revenue picture that will be reported shows the existing override. Somebody may look at that and say, well, I don't see why they need any more money. The override is a 15% increase in their spending authority. If that override doesn't pass, their spending goes down by 15%. That revenue number doesn't reflect that. On bonds, let's say a school district got money from the School Facilities Board to build a new school. When I was in the Mesa School District, we built about 27 new schools while I was there. We remodeled many more schools than that. But let's say they got $20 million, and I use that because that was talked about the other day with the Vail School District, and that shows up in their revenue. The bond is about remodeling their older schools. Someone may look and say, well, they don't need any more additional monies. Look at all those dollars they have. And the last example I'll give you is if the school district's getting a lot of federal money through special projects or through programs for disadvantaged or special education. It looks like they have money to spend on other things in the district, and those monies are very specifically limited to what they're allowed to spend those dollars on. So I just wanted to share those examples with you. I'll be glad to answer any questions, but I know you've already had a pretty long day.
Thank you. I think, though, is it not true that some of that can be explained in the pamphlet, that the schools will write that up as they're explaining the reasons why they're wanting either bonding or whatever they're building or whatever's going on, or renewing the bonding. You explain those things. You're able to do that in the pamphlet, which the voters can then understand that.
Madam Chairman, I'm not sure you can include those. It could be included in pro statements and statements against the override, but when you look at the additional language here, it says any additional per pupil revenue or per pupil expenditure information, so you can talk about per pupil expenditures, but I'm not sure that you would be allowed to explain all of those differences. I would certainly take a look at that, but I don't.
Well, okay, I'll read it again, but okay. Thank you.
All right.
Any other questions for Chuck?
Thank you very much. Appreciate the opportunity.
You're welcome.
Madam Chair, signed in to speak for is James McGarren, representing himself.
James not here.
All right. Signed in to speak against Mary Predelt, representing self. Signed in to speak against Carolyn Brown. Julie Golding, against. If necessary, against Chris Cotterman. Okay. Been there, done that. There are a whole bunch of if necessaries, and then we get into the no's and either for or against.
Okay. I really don't think it's going to confuse the voters when it comes to having information and understanding how much money is being spent. I think those that are voters going to determine whether they feel the school needs that money, and they're going to, I just think that more transparency is not going to confuse the voters. I think that the voters can figure that out. So, all right, let's go ahead and move the bill.
Madam Chair, I move Senate Bill 1378 with a due pass recommendation.
Thank you. We've heard the motion. Let's call for the vote.
Senator Bradley?
No.
Senator Gray?
Aye.
Senator Miranda? Senator Smith?
Aye.
Senator Yee?
Aye.
Senator Brocky?
Madam Chair.
Yes, you may.
I am all for transparency, and I will say that when I was president of the Washington School Board, when I first went on the Washington Elementary School Board, we were getting one open meeting law complaint a week from various constituents, and when I left, by the time I left, we were getting sunshine awards and recognition. The key to transparency for K-12 education and K-12 education finance is to simplify the funding formulas, is to simplify how we state what is being spent for what. Otherwise, instead of transparency, as this bill promises, you simply get confusion, distortion, overstatements, and misstatements. I think there has to be a better way to demonstrate how school dollars are being used, and I think the way to that is to simplify the funding formula And we've done everything else to school districts in terms of moving the bond, the election dates. I simply object to the bill, and I cannot support it, and I really hope at some point I get on a bill that Mr. Jenny supports. I just can't support this one, and with that I vote no.
Senator Allen.
Aye.
4 ayes, 2 nays, and 1 not voting.
By your vote of 4 ayes, 2 nays, and 1 not voting, you've given Senate Bill 1378 a due pass recommendation. Thank you very much, members. You're wonderful. We're adjourned.